Thank you so much, ma'am. So the final topic is genetics of ocular tumors, current and future perspectives. So we know that the human DNA is 2 meters long, and to accommodate it in a small cell and even a small nucleus, it gets compacted. First it winds around the histone proteins to form the nucleosome, and the nucleosome then itself winds around and coils to form the spindle fibers and chromatin fibers, and finally condenses to form the chromosome. So a change can occur anywhere. It could be in the DNA sequence, which is called as molecular genetics, or without affecting the DNA sequence, there could be a modification in the DNA or in the histones, which we call epigenetics. It could also be change in the chromosome, which is called as cytogenetics. Also, it could be a change in the transcript or the mRNA, which is called as transcriptomics. So with this basics, let's start with retinoblastoma. So if you see the genetic roadmap of retinoblastoma, the earliest breakthrough occurred in 1971 with the Knudsen's 2-hit hypothesis. This languished nearly for a decade until the RB gene locus was mapped onto chromosome 13q14. Subsequently, the RB protein and RB pathway were defined. The late 1990s saw an expansion in the understanding of genetics and epigenetics of retinoblastoma, and with the advent of liquid biopsy has opened up a new platform for molecular research and precision medicine. Now, Knudsen in the pregenomic era proposed that biallelic inactivation is needed for the development of retinoblastoma. He proposed that there could be 2 hits. The first hit could be nonsense mutation, a splice mutation, or a frameshift mutation, or could be a large deletion, and the second hit results in loss of heterozygosity, and the most common mechanism being mitotic recombination. And we know if these mutations are large enough, they do have genotype-phenotype correlations. So on this note, let's talk about this 1-year-old child who was diagnosed to have bilateral retinoblastoma with CSF metastasis. Importantly, you can see he has typical facial features, a supernumerary nipple. He also had coarse hands and feet. So with this, we sent for a genetic analysis which revealed the diagnosis of 13q deletion syndrome. Now, coming back, the biallelic inactivation was found to occur lower down in the maturing cone precursor cells. Also, it was found that the benign form or the retinocytoma too had the biallelic inactivation. So the question arose, is it just 2 hits? Is it just 2 hits, 3 hits, or are there more hits? So Brenda Galli proposed that subsequent to the 2 hits, there are genetic or epigenetic changes which helps in cell division and proliferation and the development of retinoblastoma. This could be somatic copy number alterations, as in 6p gain, a 1q gain, 2p gain, or even a 16q loss involving the retinoblastoma-like gene. Subsequently, mutations could also involve cell adhesion molecules like cadherin or intercellular tight junction molecules like claudin, which opens the gate for the RB cells. Again, an increase in the matrix metalloproteinases causes an extracellular matrix degradation, which paves way for the retinoblastoma cells to move. Also, a downregulation of BCOR helped the retinoblastoma cells to survive in hypoxia. So all these mutations conferred additional property to the retinoblastoma to infiltrate, invade, and metastasize. However, a subset of retinoblastoma was found to have no RB mutation, and this was a landmark paper which questioned the dogma that RB is always caused by RB1 mutation. Instead, they were found to have an amplification of the MICN proto-oncogene on chromosome 2. And this was found to occur earlier in the immature precursor cells, and hence they presented early. They were typically unilateral, more aggressive, and consisted of poorly differentiated cells. Another subset with no RB1 mutation developed retinoblastoma by a phenomenon called chromothripsis, wherein there was complete shattering of the chromosome followed by a rearrangement, and this subset was associated with more aggressive behavior and therapy resistance. The importance is that you need a whole genome sequencing along with FISH for the detection of chromothripsis. Now coming to the epigenetic changes. Epigenetic changes, as I told, without involving the DNA sequence, DNA can be modified. So it could be a hypermethylation mainly of the tumor suppressor genes like RB1 gene and beyond the RB1 gene have been proposed, and they have been associated with variable clinical correlations like heritable susceptibility, poor survival, or chemo resistance or sensitivity. It could also be demethylation of the proto-oncogenes, mainly the spleen tyrosine kinase inhibitors. The histones could also be modified by either acetylation. When you acetylate the histone, the tight bond between the DNA and the histone protein is released, and the DNA genes are exposed for transcription. This could be an important gene is again the SYK gene, or the histones could be modified by methylation, the important gene being EZH2. It could also be regulated by non-coding RNAs like long non-coding RNA, circular RNA, or microRNAs. And as far as retinoblastoma is concerned, a number of microRNAs have been found to be upregulated and downregulated, and they are currently being researched as potential biomarkers and therapeutic targets in retinoblastoma. So historically we know the biopsy of retinoblastoma is contraindicated due to the risk of metastasis. In 2012, Francis Munier introduced the safe intravitreal injection technique. This opened a new platform or a new access to the intraocular space in salvaged retinoblastoma eyes. And in 2017, Berry et al. Found that aqueous humor contains enough and measurable quantities of cell-free DNA which could act as surrogate tumor biopsy. They also found that it could predict eye salvage in retinoblastoma eyes. For example, a 6p gain was associated with 10 times increased risk of enucleation. So, the advent of liquid biopsy with the integration of multiomics paved way for personalized targeted therapy. And when you know the pathway, it is easy to target. So, we know in retinoblastoma the most commonly mutated genes are RB and MECAN, but it is difficult to target RB and MECAN directly. But our researchers have found other ways. They have found CDK inhibitors which are being researched again, or an MDM2 inhibitor like Nutilin, which has shown good results in mouse models. This is the same epigenetic pathway that I shown before. You can target the DNA methyltransferase or a histone deacetylase or SYK or even EZH2. Again, in MECAN amplified tumors, as I told, MECAN is difficult to target directly, but they found that aurora kinase A binds to MECAN and prevents its proteasomal degradation. And this aurora kinase A was found to be overexpressed in retinoblastoma. So why not target aurora kinase A? So they have again, aurora kinase inhibitors are being again researched now. So currently the targeted therapy for retinoblastoma are in preclinical trials. So continued molecular research and clinical trials will definitely pave way for more effective personalized therapies. Now coming to the uveal melanoma. If you see the genetic roadmap, unlike retinoblastoma, it is short. It was only in early to mid 2000s that the chromosomal aberrations were found to be associated with uveal melanoma. And the most important breakthrough was the identification of key genes, subsequently followed by the identification of the secondary mutations and molecular subtyping. Even though the road is short, the genetics in uveal melanoma has traveled a lot, and at present, with multiomics, we aim for targeted therapy in uveal melanoma. So first, the cytogenetics of uveal melanoma, we all know the chromosome numbers are 1, 3, 6 and 8. It could be a loss of 1p or a monosomy 3, which we know for more than 25 years has been associated with high-risk histopathological factors as well as high risk of metastasis. Or it could be a gain of 8q, and a combination of 8q gain and monosomy confers a high risk of metastasis, nearly 66% at 5 years for uveal melanoma. Now you see molecular genetics, nearly 85 to 94% of uveal melanoma were associated with mutations in the alpha subunit of G proteins, which are involved in the MAP kinase pathway. Nearly 50% had BAP1 mutation, another 15 to 30% had a mutation in the spliceosome SF3B1, and another 15 had a mutation in the translation initiation factor. So if you see the genetic evolution of uveal melanoma, the initiating mutations are GNAQ and GNA11, which are mutually exclusive, and you have the subsequent mutations EIF1AX, SF3B1 or BAP1 in the increasing risk of metastasis. And we know nearly half of the uveal melanoma patients metastasize. And currently, we do not have much effective therapy for metastatic uveal melanoma. So the ideal strategy would be to prognosticate the uveal melanoma patients so that you can detect the metastasis early. And the earliest breakthrough in the prognostication occurred with the gene expression profiling, by which they classified broadly uveal melanoma patients into two classes, and class 1A, 1B, and class 2, with the class 2 having BAP1 mutations or monosomy 3, and it was associated with a very high risk of metastasis, nearly 70 to 80%. This was probably the only prognostic test in uveal melanoma to undergo such extensive validation that now it is being used commercially on a commercial platform. It indeed was a molecular revolution in uveal melanoma. Later on, the GEP classification was modified to include PRAM mutation, that is preferentially expressed antigen in melanoma, because PRAM independently was found to increase the metastatic rate to nearly 38% in class 1 tumors. Later on, the Cancer Genome Atlas project integrated different platforms of genetic testing like cytogenetics, molecular genetics, or epigenetics, and they classified uveal melanoma to 4 molecular subtypes in the increasing order of their risk for metastasis. And as I told, metastatic uveal melanoma, we do not have adequate effective therapies now. Of that note, I'd like to highlight the effect of tebentafusp, which is a fusion protein, and it is called the BiTE in uveal melanoma, or a bispecific T-cell engager. A phase 3 trial has shown an estimated overall 1-year survival to be 73%, which was very excellent, and based on the survival benefit, this has been approved by the FDA. Now with advancements, we have a number of molecular biomarkers which have been identified for uveal melanoma, and a number of targeted therapy have been established against many pathways, including the MAP kinase pathway, or it could be oncolytic viruses and CAR T-cell therapy, which are being increasingly researched now. Uveal melanoma behaves distinctly as far as genetics is concerned from cutaneous melanoma or a conjunctival melanoma. Here you can see cutaneous or conjunctival melanoma, the main mutations are BRAF, NRAS, or c-KIT, and they do not have the definite chromosomal alterations as in uveal melanoma. And that is the reason why we have effective treatment for metastatic cutaneous melanomas like PD-L1 inhibitors or PD-1 inhibitors, and unfortunately, because of the genetic difference, we are not able to translate it to the metastatic uveal melanoma. Now coming about basal cell carcinoma. This was an 84-year-old gentleman who had history of multiple BCCs at multiple points of time, histologically proven multiple odontogenic keratocyst and multiple Palmar pits. Yes, that's a case of Gorlin-Gott syndrome or Nevoid basal cell carcinoma syndrome. Dr. Seema has very well explained the criteria, diagnostic criteria. So the basic genetics of basal cell carcinoma came from the genetics of Gorlin-Gott syndrome, and the major pathway that is involved is the sonic hedgehog pathway. We know this is a patched receptor 1 which inhibits SMO, smooth-end receptors, normally, and there is no transcription of the genes, and here you can see there is no transcription. But in basal cell carcinoma, there is an inactivating mutation of the patched receptors or an activating mutation of the smooth-end receptors, which results in activation of the glial proteins and the transcription of target genes, resulting in cancer. And thanks to the molecular research, we do have now inhibitors against the SHH pathway 2, among which the vismodegib and sonidegib has been approved by FDA for locally advanced or metastatic basal cell carcinoma. Now the time is already up. The rhabdomyosarcoma, we know broadly there are 2 types. Alveolar type is associated with fusion positivity, mainly involving translocation between PAX3 or 7 with FOXO gene, and the embryonal subtype involves chromosomal gains or losses or mutations in the MAP kinase or a TP53 pathway. So ocular tumors are vast, genetics is also even more vast, which cannot be obviously covered in 12 minutes. So I'd like to conclude by saying that advancements in liquid biopsy, multi-omics, AI-driven genetic analysis, and gene therapy can definitely improve survival outcomes and quality of life in patients with ocular tumors. The next generation holds immense potential to turn once lethal diagnosis into curable conditions with genome-driven cancer care. Thank you.
Thank you so much, Hridya. Extensively and excellently covered. I'm so proud of you how you took it through from the melanoma to conjunctival melanoma, RB, and other tumors. We can have 2 quick questions from the audience, if anything. All right, so with this, we conclude this course on ocular tumors and malignancies, where we had kind of covered, not completely, but as much as we can in this few minutes and duration that we had. And once again, thank